Thank you, sir. And good morning, everyone. And dear President, Organizing Committee, and Chamir Bandar, sir, thank you very much for giving me this opportunity on first ever mini congress to talk on Epiphora workup. So, eyes are beautiful organs which make our cells very attractive, but they are not so when they are in tears. So that's where our oculoplastic team comes in handy. So Epiphora is excessive watering of the eyes due to an imbalance between tear production and tear drainage. So there is secretory epiphora and excretory epiphora. So in our day-to-day practice, we encounter a lot of patients with tearing. Most of the time it's dry eyes, but sometimes it's diagnostically and therapeutically challenging. So it's a common epiphora. Tearing is a common presentation of many of the ophthalmic conditions, which can originate from eyelid, anterior segment, or lacrimal system problems. Most of these conditions are not vision threatening, but they can cause significant symptoms for the patient, like blurred vision, skin irritation, ocular discomfort, and social embarrassment. Sometimes it can lead to significant complications like dacrocystic abscess, and if you miss the diagnosis of a nasolacrimal duct obstruction, it can lead to post-op endophthalmitis. So it's multifactorial. Proper history and guided examination is mandatory to come to a diagnostic conclusion, which help us to do necessary therapeutic intervention and can have a happy patient at the end of the day. So let's go through some of the common causes for adult epiphora. So it's mostly due to punctum-related problems. There can be punctal stenosis, can be due to topical drugs like 5-FU, MMC, and also due to like cicatricial diseases like Stevens-Johnson, chemical injuries, ocular pemphigoid, can lead to punctal stenosis. And second most common is the nasolacrimal duct obstructions, which is mainly primary. Rarely it can caused by trauma and other nasal and sinus problems. Canalicular problems also give rise to tearing. It's not always due to mechanical obstructions. Sometimes it's due to functional problems like lacrimal pump weakness. So involutional lid laxity, entropions, ectropions, and seventh nerve palsy can give rise to tearing. So pseudoepiphora, which is due to dry eyes or anterior segment problems like uveitis, episcleritis, scleritis can lead to tearing. We should always keep in our mind some nasal pathologies also can give rise to tearing, like polyps, nasal tumors, cosmetic rhinoplasties. They can cause NLDO obstructions. Rarely, facial nerve palsy can cause aberral nerve regeneration to the lacrimal gland, which can cause increased tearing. So the way to get started is the proper history, which leads to a guided examination, and some necessary appropriate testing will help us to come to a diagnostic conclusion at the source of the problem. So in history, you have to ask about the amount of tearing. If it is very mild tearing, it is unlikely to be an NLDO obstruction. But if the tearing is pouring down the face, it is likely to be an NLDO obstruction. If the tearing is worsening towards the end of the day, and if it is increased with vision demanding activities like reading, computer work, it's more likely to be a dry eye problem. And if it is associated with pain, swelling of the eyelids, medial canthers with a mucopurulent discharge, it's more likely to be a nasolacrimal duct obstruction. And also we should always ask about any sinus problems, cosmetic rhinoplasty surgeries, because they lead to NLDO obstruction. So bottom line, a good history is always important for our guided examination. So examination always should begin with looking at the patient away from the slit lamp. So you have to look at the skin, eyelid. You have to check whether there are erythematous scaly skin around the medial canthus and the lateral canthus, which indicates there's chronic tearing with frequent rubbing. And you have to always look for entropions, ectropions, which can easily see without any eyelid manipulations. And always you have to look for medial side, the puncta, whether there's punctal entropions, which has a functional tearing problem. And always, sometimes you can miss, patient also might not come up with a partially healed Bell's palsy. So there can be reduced eye blinking. Here you can see there's browtosis, and also there can be lag of thalamus and horizontal lid laxity. And sometimes patients with blepharospasms also have tearing, not be manifest at first, but you have to ask or look for it. So next step is the physical examination. You should always look the level of the lateral canthus with the medial canthus, whether they are in line. If the lateral canthus has a downward lateral displacement, it indicates lid laxity. You can also confirm it by snap test, where you distract the lower eyelid away from the globe and check whether it reset back to the normal position without blinking. If it needs blinking, that means there's horizontal lid laxity. So then you can start with slit lamp examination. It's always you have to look for a tear leg. Tear leg is the amount of tear between the lower eyelid and the globe. If there's a decreased tear leg, that indicates dry eyes. If there's increased tear legs, obstructive pathology is likely. And you should always look for meibomian gland disease and blepharitis. And also you can, from the slit lamp also, you can see, look at the puncta, whether there's punctal ectropy and whether the punctum is in contact with the globe or whether there are punctum stenosis. And always look for conjunctival and corneal problems. So now let's move on to the appropriate testing. So there are secretory test, excretory test. So as we all know, tear breakup time, Shermer's test 1, Shermer's test with anesthetics are secretory test, but I'm going to focus more on excretory test. So this Roppler's test, it's very easy, non-invasive. You can always press the medial canthus and massage it upwards and look for a mucopurulent discharge. And it's very sensitive for nasolacrimal duct obstruction. You can always do this before a phacosurgery to avoid unnecessary major complications. So fluorescein dye disappearance test, also a simple non-invasive test where you can instill 2% fluorescein drops to the eye and wait 5 minutes and check for the disappearance. This comes in very handy in pediatric population where you can't do much manipulations. So here the right eye has completely disappeared the fluorescein dye, so it's a patent system, whereas in the left eye the fluorescein is remaining, so it's an obstructed system. So I find this Jones dye test 1 and 2 comes in handy when we do this once we want to assess the patency in a patient who's already on general anesthesia. And also we can diagnose a partial block from Jones dye test 1 and 2, where you put fluorescein dye, and after about 5 minutes you apply a cotton bud beneath the inferior turbinate, check whether it gets stained. If it is negative, do the Jones dye test 2, where you flush the remaining fluorescein dye from a air cannula. And if it is positive, that means there's a partial block. And if it is negative, that means there's a block. So we all do syringing. Syringing helps us to confirm the presence of a block, and also it helps us to locate the block. So you have to do it under topical anesthesia. You have to do punctum dilatation. Please dilate only the vertical part. Then you have to distract the eyelid laterally and you can put the air cannula. You don't need to push it up to the bone. You can only insert it to the horizontal part, initial part, then start doing the syringing. And make sure you distract it laterally to avoid false tracking. So the potential sites are the canaliculi, common canaliculus, and the NLD, nasolacrimal duct. So if there's only canalicular block, you will get the reflux from the same punctum. And the other punctum, when you are doing the syringing, it will be patent. In common canalicular block, there will be clear fluid. The fluid is clear, which will reflux from the both puncti. And NLDO block, you will get a mucopurulent discharge most of the time from both puncti. Then we have to do the lacrimal probing. Probing differentiate the common canalicular block from a NLDO block. If there's only an NLDO block, the probe will directly hit on the bone, so it's a hard stop. If there's a canalicular block, common canalicular block, you will get a soft stop because the block will go and hit the block or the membrane will go in the hit the bone, so there won't be a hard stop. sometimes in complicated cases, and also when the um, system is patent, but still some people have significant tearing, radiological testing will comes in handy. So dactyocystography, you do it using, you put a cannula and inject contrast iodinated dye, then you can get the images from using either X-ray or CT. Here you can see the cannula, then you can see the canaliculi. Here you can see the lacrimal sacs. So this is the nasolacrimal duct, where you can see the peristaltic waves. Here it's under beneath the inferior turbinate. This is the dye which is in the oral cavity. So dactyoscintigraphy is where you assess the functional aspect of the lacrimal system. It is performed using a gamma camera and nuclear drops. Here you can see a block. There's a functional block in the right lacrimal system. So sometimes CT is necessary. We almost always do NCCT orbits before DCR to exclude some nasal pathology, especially in trauma cases. So this summarizes our syringing results and the therapeutic interventions we can do for patients with blocked systems. If there's a nasolacrimal duct block where the mucopurulent discharge comes out, you can do either external DCR or endoscopic DCR. And if there's only a canalicular block, you can do canalicular reconstruction with stenting. If there's a partial block, you can do a balloon dilatation. And if in complicated cases or repeat cases, when there's a common canalicular block, you can do a conjunctive DCR. So with that, I conclude my presentation. Thank you very much for your patient listening.